Well, first of all, we wanted to thank you for being here, Dr. Sorin Pislaru. He is a part of the Division of Structural Heart Disease of the Department of Cardiovascular Medicine in the Clínica Mayo. And we are very grateful for you being here, and we want to thank you for that. It is very important, your participation. We are now starting with the presentation of the case. Vamos a presentar a un paciente de sexo masculino de 70 años de edad con hipertensión arterial, dislipemia y extravaquismo como factores de riesgo cardiovascular. Como antecedentes cardiovasculares tenía un reemplazo valvular aórtico con la prótesis biológica número 21 y una cirugía de revascularización miocárdica con una lima a la de A y un puente venoso en la circunfleja. Al mes del reemplazo valvular tuvo una endocarditis protésica precoz con hematocultivos 3D3 para un streptococo epidermidis, por lo que cumplió el tratamiento antibiótico con daptomicina por 6 semanas con buena evolución clínica posterior. Como otros antecedentes, tenía apendicectomía, colecistectomía, un reemplazo de cadera, y venía medicado con bisoprolol, aspirina, atorvastatina y ezetimibe. En mayo del 2021 se presenta al servicio de emergencias refiriendo un síncope con TEC en la vía pública. Al examen físico estaba normotenso con la frecuencia cardíaca normal, se auscultaba un soplo sistólico eyectivo, 3 sextos de foco aórtico, estaba lúcido y presentaba una herida cortante enfrente secundaria al síncope. Se realizó una tomografía de tórax donde se vio profundización de los surcos y cisuras como signo de involución cortical, leucoaraiosis, pero no presentaba colecciones hemáticas intra ni extraxiales. Se realizó una tomografía y un electrocardiograma donde no se observaron signos de importancia. En la radiografía no tiene redistribución de flujo, y en el electrocardiograma solamente se observan signos de hipertrofia y sobrecarga sistólica del ventrículo izquierdo. Se realizó un ecocardiograma Doppler porque el paciente presentaba un soplo y venía por síncope. Se observa la válvula biológica en posición aórtica con engrosamiento de sus válvulas que tienen movilidad reducida también, y con el Doppler color se observa un flujo turbulento a través de la válvula. Cuando exploramos esa válvula con el Doppler continuo, vemos que tiene una velocidad de casi 5 metros por segundo, un gradiente medio de 58 milímetros de mercurio, un área efectiva de flujo de 0,5 centímetros cuadrados y con dosis indexada de 0,3 centímetros cuadrados por metro cuadrado, y un índice Doppler de 0,15, claramente compatible todo con una disfunción protésica. Para completar el estudio de la disfunción protésica se realizó una angiotomografía de multi-slice, donde se observa este material, que es predominantemente hipodenso entre 40 y 70 unidades Hanfield, que tapiza todo el interior del stent de la prótesis y genera todo un engrosamiento valvar, que todo eso sugiere la presencia de trombo, y en menor medida también se observaron áreas con densidades más elevadas, de hasta 120 unidades Hanfield, que sugieren material en diferentes estadios de evolución, lo que sugiere que hay trombo asociado a algún grado de generación protésica. En ese momento, con el diagnóstico de trombosis protésica, se inició tratamiento anticoagulante, y al mes posoperatorio se observó una disminución significativa de los gradientes disminuyeron casi un 40% en comparación al estudio de la internación, por lo que se supuso que el paciente había presentado una buena respuesta al tratamiento anticoagulante. Entonces con esto concluimos el caso clínico, y le damos la bienvenida nuevamente al doctor Pislaru, que nos va a deleitar con una presentación que él nos tiene preparado, respondiendo muchas de las preguntas que surgen con el caso clínico y también agregando información sobre otros tipos de disfunción protésica, como son la degeneración y el PANUS. Hi, Dr. Pislaru. We are now wanting to hear you, and now all you have to tell us.
Well, Mariana, first of all, thanks for the invitation. It's always a pleasure to be present at the pre-congress of the Institute of Cardiovascular Disease in Buenos Aires. We have great friends there, and it's always a pleasure to share cases with you guys. So I'm glad you picked up bioprosthetic thrombosis, because this is an area that was of great interest to me. So it's a little bit of a passion there. And I was asked to comment whether prosthetic valve dysfunction does always need surgical intervention. And here are a couple of things that I'd like to go through with you guys. So when you choose the therapeutic strategy, you have to answer some key questions first. So it's very important to start on the right foot. We're going to go over some misconceptions in valve thrombosis, and then we're also going to go over some issues with the valve-in-valve implantation, because this is an increasingly popular therapeutic strategy. So the key questions for therapy are two. First is the question of the mechanism. You need to be nearly certain whether this is thrombosis, whether that's degeneration, or whether that is an infection, because all three can lead to prosthesis dysfunction, whether that be obstruction or regurgitation or a mixed mechanism for the two. The second question is, if you're going to go for a valve-in-valve procedure, if you even contemplate that, you will need to carefully assess the anatomy, because you look at the coronary artery origin and perivalvular pathology, and we'll go back to that a little bit. So let's go over some misconception in bioprosthetic valve thrombosis. So your patient seems to have bioprosthetic thrombosis. It was shown by CT. It was proven therapeutically because he responded to warfarin anticoagulation. So some misconception. First misconception is that bioprosthetic valve thrombosis is uncommon, and really that surgical valves are unaffected, much less so than the transcatheter aortic valve replacement. And these are corrected in so many papers, it's by now shouldn't be even thinking about it. The most important two came just last year, where the core valve and the partner 3 groups reported the low risk aortic stenosis trials, and this had a mandated CT sub-study. The investigators were blinded to the CT sub-study, and what they shown was that there's massive incidence of valve thrombosis. So in the core valve study, the incidence with TAVR and SAVR at 1 year was nearly 30%. Around 30%, and it was exactly the same with surgical valves or transcatheter valves. In the partner trial, at 1 month there was a little less, but at 1 year the difference was not significantly different between TAVR and SAVR, and again 20 to 30% incidence. So this is not a rare disease. The second misconception is that it occurs only early on after implantation. Everybody will think of valve thrombosis at 1 month, 3 months, 6 months, but look what happens if you go in time. So these are valves that had some form of an intervention at the Mayo Clinic, and what you can see as you go from the time zero of implantation in progressive years, you can see less and less of the bioprosthetic thrombosis and more of the bioprosthetic degeneration. So you can almost play odds. For your patient who was at 2 or 3 years post-implantation, you would guess most of the time this is going to be thrombosis, although you can see degeneration early on just the same. But the vast majority will be thrombosis. Third misconception is that bioprosthetic valve thrombosis is an easy diagnosis. I'm really very happy that you chose to add more imaging to your patient, because you had a high gradient, and the easy answer would be, well, you have a high gradient, it's probably something wrong with the valve, but you don't know exactly what it is. It turns out that bioprosthetic valve thrombosis is frequently ignored. In a retrospective series, we found that up to 90% of the patients are not recognized, and therefore we proposed some simple echo criteria for initial triage, or these are for transthoracic. So if you have a gradient increase more than 50% from baseline, if your leaflets are thickened but not calcified, and if you have restricted leaflet mobility, these are fairly sensitive and specific for bioprosthetic valve thrombosis. But of course, you'll need to confirm the diagnosis. And this is how the typical aortic valve bioprosthetic thrombosis look like on the left, where you have free edges. So the edges usually are not thrombosed. The thrombus is located, as in your case too, in the cusp of the leaflet towards the base. And look in comparison with the degeneration. You have thick leaflets, but these are very echo bright, so these are unlikely to be thrombosed. This is most likely to be fibrosis or calcification of the bioprosthetic valve. It is very, very important to confirm with TE and CT, and very important also, everybody who has a thickened leaflet of a bioprosthesis and a high gradient, do not assume it's the generation of thrombosis. You have to actively look for infection, because about 5 to 10% of the patients presenting with obstruction actually have endocarditis that you pick up later. So it's very important. Final misconception that I'm going to show is that oral anticoagulation restores function in a quick way, and that is not entirely true. So we looked at patients who did respond to oral anticoagulation, meaning that their gradients restored once we treated them with warfarin typically. But if you look at the prosthesis position, tricuspid, aortic, and mitral, what you see is that at 6 months, most of the mitral valves have resolved, whereas the aortic and tricuspid valve, only about 50% of the patients have completely resolved their gradient. So it means it takes a little longer for the aortic and tricuspid valves to fully resolve. And in this study, over half of the patients needed more than 3 months oral anticoagulation. So your patient responded at 1 month, which is great, but not everybody does so. Everybody, though, who will eventually resolve the gradient does have some form of a response at 1 month. So what we usually do is check them at 1 month. If they respond even a little, we continue anticoagulant therapy. Bioprosthetic thrombosis, is that a benign condition, meaning that you treat it and it's gone and forget about that? And the answer to that is no. So we look patients who, again, were treated for bioprosthetic thrombosis. And of the 62 who did resolve the initial episode, 14 of them had recurrence of valve thrombosis. So that is 1 in 4. So it's a lot of patients who have a second or third and sometimes a fourth episode of valve thrombosis. And importantly, if you look at these patients who did have valve thrombosis in long-term follow-up, what we see that those who have bioprosthetic thrombosis are much more likely to require reintervention on the valve because the valve has accelerated degeneration. So this is not a benign condition. Are there issues with valve in valve? Of course, the size is important. It's just like Russian dolls, okay? You cannot put smaller and smaller and smaller valves. So especially for prostheses that are 19 or 21 millimeter in the aortic position, valve in valve, usually it's not an option. Many of these patients may need to go back to surgery. Importantly, when you do a valve in bioprosthesis, is to remember that you have the skirt of the leaflets of the first prosthetic valve become the secondary skirt of the new valve, and you may occlude the coronary ostia, and that's a tragedy because mortality is about 50%. This patient that you see here with left main impingement is already on ECMO, so the patient is essentially already in the OR for an intervention because they are in bad shape. Also, issues with access of the coronary ostia after you put a valve in valve, especially if it's TAVR in TAVR. So this is tricky, and this is a very elegant study coming from the radiologist who calculated a theoretical inability to access the coronary ostia, and it turns out that it's different if you start with core valve and then you put a new valve in, or if you start with SAPIEN. So if you start with a core valve and you put another TAVR inside of the core valve, they estimate the risk of not being able to access the coronary ostia. It's almost a third, whereas the SAPIEN it's a little better because the stent height it's a little less. So how do you select then the therapy? Well, so remember, prosthetic dysfunction, established thrombosis, degeneration, and infection, and it's really a must to do a CT or TE and the blood culture and infectious workup. You have to do that. If you have thrombosis, most of the patients respond to anticoagulation. On rare occasion, patients have resistant thrombi, and then you have to go either to valve-in-valve or surgery. There's no other way around that. Degeneration, most of the patients these days will have a valve-in-valve procedures if they have a favorable anatomy, but some will require surgery. And of course, infectious etiology, you treat first with antibiotics, but in reality, many of these patients will eventually go to surgery. So not everybody needs surgery, but there's a lot of selection to do. Thank you.
Thank you. Thank you so much. It was very clear and excellent, your presentation. I have one question about our case. Do you think that the history of an infective endocarditis, in an early infective endocarditis, have played a role in the thrombosis formation?
It's quite possible, you know, so there's a lot of discussion, what is first, the chicken or the egg? So is the thrombus a nidus where you can seed infection and then you develop endocarditis, or the other way around? But there's a fairly strong activation of coagulation once you have an infectious process. As you know, the vegetation is actually thrombotic material that just happens to have all sorts of bacteria growing, and of course white cells, and so on and so forth. So in your patient who probably had endocarditis earlier on, then yeah, it may have been the cause of valve thrombosis. And I presume that you did test for infection before anticoagulating him, because otherwise you got really lucky.
Yes, that is very interesting, because we are seeing a lot of patients that with that sequence of events, and I find that very interesting.
Yeah, so for our protocol here is whenever you suspect valve thrombosis, we go CT or TE depending on the position of the valve. In general, aortic prosthesis, we do CT. Mitral, tricuspid, pulmonary, we usually do TE first as a first line, and then if they're inconclusive, then we choose the other. And in everybody, we do systematic blood culture, see reactive protein and sedimentation rate just to look for infection.
Okay, thank you so much. You are very good, and you are excellent in all your right and all that.
Well, thank you very much, Mariana. Thanks for the invitation. All right.
Thank you to you.
Okay.